Hello, my name is Dr. Ukiri Richard. I am giving you this podcast today on basic cardiology. Today we are going to talk about recurrent fever spikes. We are using the case of a 33-year-old male patient that has been known since 2004 to have Crohn's disease and has been having recurrent fever spikes in the last 6 months. His treatment with mesalazine, the dosage has been increased and had to be even supported with prednisolone. Under this therapy, he came to a severe exacerbation 4 weeks ago. Aside them, he had to be given addictive azathioprine. Because of the worsening general condition and the recurrent fever spike, the patient had to be admitted. On the admission day, an abdomen tomography was done where there were no signs of abscess or other pathologic finding. We only saw only a splenomegaly. The patient was presented to you because during the auscultation, they heard a loud systolic murmur that has been until now not been known. There's no previous cardiac diseases. On examination, the general condition was reduced. The lungs were fried. Jugular venous pressure was normal. The heart rate was regular, 120 per minute. There was an early hollow systolic murmur in the 3/6 over the herb area with radiation to the carotids. Blood pressure was 90/60 millimeters of mercury. Abdomen was soft. There was diffuse tenderness. Bowel sounds and peristaltics were normal. The spleen was palpably enlarged. Liver was okay. The kidneys were also free. And peripheral pulse were palpable. There were no pillar edema and there were no pathologic neurologic signs. In the laboratory test, you saw a constellation that was suggestive of infection with slightly elevated CRP. The procalcitonin was elevated and you had a severe leukocytosis as well as a lightly fasting ESR. Apart from that, you saw a normochromic pneumocytic anemia with hemoglobin of 9 grams per dl as well as a hypokalemia of 2.8 millimole per liter. The LDH was normal. The renal function test, TSH, were normal. Total albumin and total protein and albumin were minimally reduced. The other values were normal. What are you now going to do? That's my question. Simple and direct. Well, I will actually do an ECG and echocardiogram as well as look for other focus of infection like from chest x-ray onto the dental status. Despite the fact that I already have the computer tomography of the abdomen, I will still do an abdomen sonography. I'll do urinalysis and check for bacteria in urine. I will take blood culture. Actually, 3 separate blood cultures in aerobe and anaerobe bottles within 24 hours with at least 1 hour interval. And if necessary, I will also do for fungal culture. Okay, in the ECG you did, you saw a typical clockwise atrial flutter with, in most cases, 3-to-1 conduction and a ventricular frequency of about 110 per minute. In the echocardiogram, you saw a hyperdynamic contracting left ventricle without regional wall motion disturbances. The left atrium was slightly dilated. The other heart chambers were okay. Aortic valve, tricuspid valve, pulmonary valve were mildly sclerosed with normal movement. There was reflux across the tricuspid valve. The ROV, that's right ventricle and right atrium, maximum pressure gradient was 25 millimeters of mercury plus central venous pressure. Inferior vena cava was normally dilated, was normal size with normal respiratory modulation. On the distal part of the anterior mitral leaflet, you saw a fluctuating echo arm structure of about 6 millimeters of length. Due to that, you have an eccentric regurgitation jet towards the medial with a vena contractor of 4 millimeters and a moderate mitral valve regurgitation. In the area of the mitral valve annulus, you did not see any evidence suggestive of a ring abscess, and there were no pericardial effusion. The chest X-ray was normal. The dental examination and X-ray were normal finding. Apart from splenomegaly, the abdominal findings were all so normal. So what diagnosis are you now suspecting, and how can you get hold of this diagnosis? The patient has most probably a mitral valve endocarditis under immune suppression therapy. In transesophageal echocardiography, though the patient was, the judgment in the transthoracic echocardiography was enough, but in the transesophageal echocardiography that was done, the vegetation was seen again, and you were able to judge the size of the vegetation as well as the paravalvular abscess, which was identified in the transesophageal echocardiography, and you were able to determine the grade of the mitral valve insufficiency and regurgitation. Just to let you know again, both mitral valves were a bit sclerosed. The anterior mitral valve leaflet was thickened with a 10 millimeter long echo arm oscillating structure was seen attached, which was likely to be a vegetation. Aortic valve or tricuspid, lightly sclerosed, but with normal opening. There were no regurgitation. The other valves morphology were okay, even in Doppler examination. The left ventricular function was normal. There were no pericardial effusion, and the atria were visualized to be mildly dilated. The right ventricle had normal size, and there were no thrombus in left atrium or left atrial auricular appendage. I have a schematic diagram now of when to do transthoracic or when to do transesophageal echocardiography when you suspect an endocarditis. If you have a clinical suspicion of endocarditis, first of all, you do transthoracic echocardiography. If during the transthoracic echocardiography you have either a patient with a prosthetic valve or prosthetic cardiac material, or you are not able to have a good view, or you have positive finding suggestion of an endocarditis, you go forward to do the transesophageal echocardiography. If you have negative findings, but you still have suspicion of endocarditis, if the suspicion is high, please go forward and do your transesophageal echocardiography. But if it is low, you stop. And don't forget that even in these cases where transesophageal echocardiography I have listed as indicated, if you cannot find endocarditis or vegetation and you have strong suspicion, you may need to repeat the transesophageal echocardiography after 7 to 10 days. Now let me tell you something. The transesophageal echocardiography really helps when you suspect, or helps in confirmation of the diagnosis of an endocarditis. Could you tell me how, or detail out the diagnosis criteria of an endocarditis in the transesophageal echocardiography? Well, to get to the diagnosis of the endocarditis, you have to put the clinical, labochemical, and echocardiographic findings together. Very helpful in this case is the Duke criteria, modified Duke criteria, which was adopted in 2009 by the European Society of Cardiology. The HOP criteria are: 1. Positive blood culture. 2. Evidence of endocardial involvement. So let me draw you back to the HOP criteria again. As I said, 1, positive blood culture, and 2, evidence of endocardial involvement. In the positive blood culture, you could have evidence of typical microorganism that cause infectious endocarditis in 2 different blood culture, and B, you have permanent positive blood culture with numbers of microorganism that can cause an infective endocarditis. Let me break it down again. In this positive blood culture, when you have an evidence of microorganisms in 2 cultures that can cause, with organisms that can cause infective endocarditis, it could be Streptococcus of the viridans group, Streptococcus bovis, or infection, the what German called HACEK group, or it could be Staphylococcus aureus or Enterococcus when you don't have any other primary focus. 2, if you have permanent positive blood culture with evidence of microorganism that can cause an infectious endocarditis, defined as 1, more than 2 positive blood culture when taken at an interval of more than 12 hours, or 2, 3 blood culture or positive or more with separate blood culture with intervals more than 1 hour. So those are the criteria for the positive blood culture. Now we are talking about the evidence of endocardial involvement. It could be positive echocardiography findings, or it could be new regurgitation of the heart valves. The positive echocardiographic findings will be free fluctuating structure on the heart valves or in the area, a surrounding area, with a regurgitation jet or an implanted material after you have excluded an anatomic dysfunction or abscess or dehiscence in the prosthetic valves. So we are still talking about the evidence of endocardial involvement when you have new regurgitation of the heart valves. So those are the 2 main criteria: positive blood culture as listed above, and evidence of endocardial involvement. But the other criteria: predisposition, fever above 30 degrees centigrade, embolization in gross big arteries, septic pulmonary infarction, mycotic aneurysm, intracranial bleeding, conjunctival bleeding. If you have immunology phenomenon like glomerulonephritis, Osler's node, red flecken, or positive rheumatic factors, it could be microbacterial indication, for example, positive blood culture that don't meet the main criteria. that means when you have culture of organisms that are not usually known to cause infective endocarditis. 6, when you have echocardiographic criteria that are in keeping with an infection of endocarditis but do not meet the Hub criteria. So, according to the Duke criteria, an infective endocarditis can be sure when you have 2 Hub criteria, or 1 Hub criteria and 3 other criteria, or even 5 other criteria. It is also possible if you have 1 Hub criteria and 1 other criteria, or even 3 other criteria. This our patient actually has met main criteria 2A1 and 2B, as well as 2 other criteria. So, we are very sure of an infective endocarditis, despite the fact that we have not even have the blood culture results. Okay, that is very good. Let me ask you a very sensitive question. Do you follow the spectrum of the organisms according to the culture and the antibiotic spectrum resistogram, or do you follow the spectrum based on the frequent organisms that are known to cause infective endocarditis? What I mean is, if your culture comes out and you see an organism with an antibiogram that is different from those of the commonly known antibiotics that are useful for infective endocarditis, which will you follow? Well, in this patient, with this constellation, the decisive factor yet is to complete your collection of blood cultures before you start antibiotics. When you talk about typical bacterial spectrum, you must know that there's difference between native and prosthetic valve endocarditis. You must also put into consideration the patient's age. If necessary, you may need to call the ENT and the ophthalmologist to look for more focus, but in this case, those were also normal. The risk constellation for endocarditis, the most affected valves are the aortic and mitral valves. An isolated aortic valve endocarditis can be seen in 55 to 60% of cases, and isolated mitral valve endocarditis in 25 to 30% of cases. A combined aortic and mitral valve endocarditis can be seen in 15% of cases. A right heart endocarditis in 10 to 15%, which is usually less often. The incidence is usually for new infection about 6 in 100,000, and the predisposing factors are congenital or acquired heart valve disorders. Well, and here you also have to consider the high risk, intermediate risk, and low risk group. The high risk group are patients that have had a heart valve replacement, patient that has had endocarditis, patient with congenital complex cyanotic heart disturbances, singular ventricle, transposition of great arteries, tetralogy of Fallot, open ductus brutali, coarctation of aorta by bicuspid aortic valve, systemic pulmonary shunting or conduit, twist and neck case after post rheumatic fever that has affected the heart. Those are the high risk patients. Intermediate risk patients had other congenital heart failures, atherosclerotic damage to heart valves, mitral valve prosthesis with murmurs, mitral regurgitation with or thickened leaflets, isolated mitral stenosis, and disease of tricuspid valve, pulmonary stenosis, hypertrophic obstructive or non-obstructive cardiomyopathy. The low-risk group are atrial septum defect of the secondum type, ischemic cardiomyopathy, patient after bypass operation, mitral valve prolapse, or thickened mitral valves, or regurgitation. The common causes, bacterial causes of, or common cause of endocarditis are streptococcus, Staphylococcus aureus, coagulase negative staphylococcus, enterococcus, gram-negative bacteria, fungi, negative blood culture, and Hasek organism, then Corynebacterium. It depends on the age, but I do not have time to break all those ones down. Don't also forget that every form of intravascular or cardiac foreign body, especially this pacemaker and ICD electrode implantation. This implantation rate of the pacemaker and ICD electrode has been increased in the last years, so that the predisposition of our patient has also been increased. So now let's talk about the therapeutic options you have in this patient. What points are you going to consider your choice of antibiotic? Which antibiotic regime will you suggest in this our patient? After collection of the blood culture, we have to start an antibiotic treatment. And endocarditis can actually be controlled with medications. Sometimes there may be valvular defects left after the infection. In this case, there may be a constant mitral valve regurgitation that is left that may need to be operated on after on, or done or reconstructed. We really have to consider an antibiotic therapy, and the choice of the antibiotic therapy will depend on if he has a native or a prosthetic valve endocarditis. And on the other side, we have to look at the causative organism. Very important that we have to cover all the expected organisms. For example, we have to cover the organisms. In this case, because this patient has a chronic colon infection with enterococcus as more possible cause with immune suppression, we also think of fungal infection. We have to make the antibiotics intravenous, and we have to correct the antibiotics when we have the antibiogram spectrum. So I have a plan here on antibiotics you have to give and how long, and some commentaries. If you have a native valve, you may give ampicillin sulbactam 12 grams per day at 4 divided doses for 4 to 6 weeks. Or you may give amoxicillin clavulanic acid with gentamicin. Amoxicillin clavulanic acid 12 grams per day in 4 divided doses, and gentamicin 3 milligrams per kilogram per body weight, or intravenously or intramuscularly 2 or 3 times a day for 4 to 6 weeks. That is, all these are native valves. You could also give vancomycin 30 milligrams per kilogram per body weight twice a day for 4 to 6 weeks, with gentamicin 3 milligrams per kilogram per body weight intravenously or intramuscularly 2 or 3 times a day, and ciprofloxacin. So the first one, in native valves, you can give ampicillin sulbactam or amoxicillin clavulanic acid with gentamicin, or you can give vancomycin with gentamicin and ciprofloxacin. It has to be 4 to 6 weeks in infective endocarditis. If you have a prosthetic valve, you give vancomycin 30 milligrams per kilogram per body weight intravenously twice daily for 6 weeks, with vancomycin with gentamicin 3 milligrams per kilogram per body weight intravenously or intramuscularly 2 to 3 times a day for 2 weeks, and rifampicin 1,200 milligrams per day orally twice daily. I will have to add that in prosthetic valve that have been existing more than 12 months post-operatively, they have to be treated like that of a native valve. In this our patient, okay, after 2 days, we got a culture of Enterococcus faecium. What are you going to do? Infection of endocarditis with Enterococcus species, they respond very well to amoxicillin with gentamicin, or ampicillin with gentamicin, or vancomycin with gentamicin. Generally, the recommended antibiotic therapy is backed with a lot of guidelines. So, after 10 days of your treatment with antibiotics, the parameters of infection were significantly bettered. There were no fever, and the procalcitonin was negative. The patient could tolerate the antibiotics, and the vegetations you are still seen in the transesophageal echocardiography to be 10 centimeters long, with some, I think, with increase in size. The mitral valve regurgitation was still moderate as before, and there were no indication for a periannular abscess. But the patient experienced a transitory ischemic attack in the early morning and also in the afternoon. You did a computer tomography of the brain that was normal. Do you then need to change your therapy concept? Even when the computer tomography was normal, I really have to think about a septic embolization and consider a prompt operative intervention. Indications for an evident grade of a surgical intervention: 1. Acute aortic regurgitation or mitral valve regurgitation with hemodynamic instability, paravalvular abscess, and fistula formation. 2. MROS, that is methicillin-resistant Staphylococcus aureus, or fungal endocarditis, persistent fungal or bacteremia despite therapy, recurrent embolism after adequate antibiotic therapy, prosthetic endocarditis. 3. When you have severe sepsis more than 48 hours, persistent fever. Don't forget drug fever still exists. But when you have persistent fever more than despite adequate antibiotic therapy for more than 5 to 10 days, when you have fresh mobile vegetation more than 10 millimeters on the mitral valve, and you have increase in size and width of the vegetation and acute cerebral embolization. Okay, please tell me other possible complications of infective endocarditis. Well, cardiac complications like heart failure, myocarditis, pericarditis, formation of a periannular abscess. Vegetation can spread extracardial complications like cerebral embolism, also bleeding, mycotic aneurysm, mycotic abscesses, acute renal failure, and also rheumatic complication. This your patient, after undergoing an operative valvular replacement, do they need endocarditis prophylaxis? Which patient generally needs endocarditis prophylaxis? And does the patient need to take antibiotics post-operatively? Generally, the antibiotic therapy, according to the guidelines, have to be done in native valve for 2 to 6 weeks and in prosthetic valve for at least 6 weeks. In this patient with a native valve endocarditis that progressed to have a valvular replacement, the preoperative native valve regimen has to be continued, and the length of treatment has to be counted from the first day of antibiotic treatment. If post-operatively you have a new culture, then you can consider a new regimen, which will depend on the cultured organism. Only in patients that are high risk for endocarditis require endocarditis prophylaxis. And this our patient actually falls into the group of high risk and should require endocarditis prophylaxis. So recommendations for endocarditis prophylaxis according to Habib. Antibiotic prophylaxis only in patients with high risk of infectious endocarditis. 1. Patient with prosthetic valve or after heart valve reconstruction that use prosthetic material. 2. Patients that have had endocarditis. 3. Patients with congenital heart diseases that are not operable cyanotic congenital heart disease or residual defects and palliative shunt or conduit. 2. Patients with congenital heart disease with complete management of the congenital heart diseases when prosthetic materials were used, either surgical or percutaneously, until 6 months after the procedure. And 3. Patients with congenital heart disease that have residual defects after treatment with prosthetic materials or devices like heart operation or percutaneous intervention. There is no recommendation for antibiotic prophylaxis in other heart or valvular or congenital heart diseases. Now, the cases where you need prophylaxis are dental procedure, antibiotics by manipulation of, let me not go into that, respiratory tract infection, including bronchoscopy, laryngoscopy, transnasal or endotracheal intubation, gastrointestinal or urogenital tract like gastroscopy, coloscopy, cystoscopy, transesophageal echocardiography, and skin or soft tissue disease. Here, antibiotics is not recommended. Here, the recommended antibiotic prophylaxis is amoxicillin or ampicillin, 2 grams per ounce or intravenously for adults, or 50 milligrams per kilogram for children per ounce or intravenously. That's if you do not have penicillin allergy. But if you have penicillin allergy, you give clindamycin 600 milligrams per ounce or intravenously, or 20 for adults, or 20 milligrams per kilogram for children. Just a concluding question. This patient, don't forget, presented with atrial flutter, and in the transesophageal echocardiography, you did not see any thrombus in the left atrium or left atrial appendage. Did you think it will require an immediate electrocardioversion, and what will you do about the anticoagulation? Well, in spite of the high mobile vegetation in the mitral valve, the electrocardioversion has to be really considered with care, especially in this patient, especially in patients that are unstable in their hemodynamic value. In terms of anticoagulation, in this case, we will give an intravenous heparin with close control of the PTT. Thank you very much.